Good morning.
Good morning.
Okay. I know some of you are still joining the session. Can you hear me okay, everyone?
Yes,
Yes,
ma'am.
Yes.
yes.
Perfect. Thank you. Thank you. Thank you. Well, good morning again, and welcome to your very last class. Today, we are going to be discussing stress and coping as it relates to Parkinson's disease. And I know you were introduced to the topic of stress and coping previously. So hopefully you'll be able to kind of apply what you've learned on the topic and relate it to not only the person who suffers from Parkinson's disease, but of course the family members as well. I will be showing you a 12-minute video at the end, which I really think encompasses a number of the topics that we've discussed together over the course of this year. You'll hopefully be able to identify the collaboration, the family dynamics, family-centered care, the interprofessional teamwork, and of course, as we go through this, we're talking about the concept of mobility as it relates to Parkinson's disease, along with stress and coping. And I'm really looking forward to hearing your thoughts about that video. We may or may not take up the 2 hours. I know you guys are preparing for your final exam, and everything's pretty straightforward. But we'll review it. So before I begin, though, just in case I lose some of you near the end, I just wanted to say what an absolute privilege it's been to teach you this past year, and I really wish you all the best going forward into your last year next year. And thank you for your attentiveness and your professionalism. I really appreciate it. This was a first for me too. This is my first year of teaching, so I've enjoyed it, and oh, I'm getting emotional. So wish I could have spent some in-person time with you a little bit more, but it's been great. So thank you very much. I appreciate your feedback and certainly your attentiveness. Okay. Thank you. You're welcome. You're welcome. You're welcome. All right. So let's get going. All right. Let's see. All right. So concept, stress, and coping. That's what we're going to be reviewing today. I'm sure you've probably looked at that real quick. All right. So this is just a slide. Again, I don't want to go over things that you've gone over. I just kind of want to refresh your memory. So stressor, external influence that threatens to disrupt the equilibrium that is needed to maintain homeostasis. And obviously the body's ability to maintain a stable balance. We're constantly fighting for that, right? Internally, our body is always fighting for balance. These stressors, however, may be physical, mental, and emotional, and both positive and negative depending on the person's perception of the experience. So not all stress is negative, right? So, we feel stress, and stress is kind of an indicator to our body, either that something wrong is wrong or something is important, right? And it focuses our attention. All right, so as it relates to Parkinson's disease. So the autonomic nervous system controls your heart rate, your breathing, your vision, and it's a built-in stress response for the fight or flight response. It helps the body face stressful situations. I know you've heard about this fight or flight response probably throughout your your learning career. So basically, this is an evolutionary adaptation, um, our that increase our chances of survival. So this is something that's built in for us. Obviously, way, way, way back in the day, that was like surviving out in the wilderness. And but the bottom line is that that nervous system response is kind of the same. So when a person has long-term chronic stress, um, it's continuously to be it continuously is activated, and you can imagine if your fight or flight is continuously activated, it can cause a lot of wear and tear on your body because of course when you respond to that fight or flight, your heart rate goes up, your blood pressure goes up, your acuity is very intense. So if you're continuously kind of in that fight or flight, it's going to take a toll, right? Both physically, emotionally, and behaviorally, you're going to develop symptoms due to that. So Parkinson's disease may experience anxiety as part and parcel of their PD itself, and it's caused by the chemical imbalances in the brain. So unfortunately, what that's saying is basically that it's not just that something's happening that the fight or flight is kicking in, it's something internally. These chemical imbalances are causing this response, this fight or flight. But in addition, you can imagine if you have somebody that has Parkinson's disease or any type of disease or anxiety driven disease, um, that's going to in itself cause anxiety. So external symptoms are going to cause anxiety. So if you have symptoms, which we'll talk about, of Parkinson's, where you can't control your movements, that's going to cause anxiety, like going out into public, trying to do things, trying to eat. That's going to increase your anxiety. So it's obviously no shock should come to you that somebody that has Parkinson's disease, it's very common for them to suffer from both anxiety and accompanied by depression, right? So we're managing a lot of things there, not only the motor functions, but the non-motor functions that come along with that. And as a nurse, what role do we play in that as far as education and implementing things to help alleviate that? All right. So while Parkinson's is commonly associated with deterioration of motor function, as I just said, and mobility, many patients routinely report non-motor symptoms such as mood and cognition issues, with up to 50% experiencing depression. And stress has been found to be a prominent factor of disease progression. So not only is it a side effect, but it can actually exacerbate the disease itself. Pathophysiology. I'm never going to ask you the pathophysiology, but I do think it's important that you kind of just have a general understanding. So Parkinson's disease is a complex motor disorder that can cause uncontrolled movements. It typically occurs due to the low levels of dopamine in the brain, and dopamine plays an important role in movement and coordination. About 1.5 million people in the United States currently have Parkinson's disease or are diagnosed, and I guess approximately 60,000 receive a diagnosis each year, which is just devastating. So basically, dopamine and acetylcholine, you can kind of see on your screen, are two neurotransmitters that are imbalanced in Parkinson's disease. Motor and cognition function depends on the coordination and the interaction between these two neurotransmitters. And levodopa is a medication used to help restore these kind of motor skills. And we'll be talking about that a little bit later. And again, you don't have to know this, but just be aware that, dopamine is a factor in the process of Parkinson's disease, and the loss of dopamine is going to cause an impact on their coordination. Um, you also see the presence of Lewy bodies disease, and I think I'm going to touch on that a bit later because we talked about that way back during our cognition when we talked about Lewy bodies dementia. Okay, it's a buildup of um, s- like proteins, I believe, on in the cells that cause cognition issues. But again, you just be aware of that. All right. So overview: Parkinson's disease is a progressive degenerative neurological disorder that primarily affects movement. It's characterized by tremors. Usually might start with unilaterally, like one hand tremor, and then it progresses to bilateral. And the other symptoms are muscle rigidity, bradykinesia. You definitely should know that word, bradykinesia. It's slow movement and postural instability. So you should also, as a nurse, always be aware of obviously the symptoms. So the causes, so that's the problem, right? The exact cause is unknown. They suspect that it's likely genetic and exposure to possible environmental factors. Some people think maybe there's a long exposure to certain medications. In some cases, it seems to be hereditary, but not always. But not always. Risk factors, they increase with age. Men are at higher risk living in a rural area. I'm not sure why that is. Actually, that's interesting. Certain occupations and genetic mutations. And there's really no definite way to prevent it as of now. That's the difficult part, right? So not knowing exactly the cause makes it a little different difficulty to come up with, a cure. And obviously, that we've spent a lot of time and research in this, but as of now, there's no cure. So clinical manifestations. So this is just a picture of some of the manifestations that happen. It's mild at the beginning and it progressively gets worse over time. And you can imagine somebody that's diagnosed with this early on, and they're told, and they look to see what's waiting for them, and they do the best they can, but it's that in itself can cause some anxiety and depression and worry. And they worry about not themselves, but they worry about their family members as well. And the clinical manifestations have both motor symptoms and non-motor, which we touched a little bit on already. So the motor symptoms. So again, the trembling of one hand is an early sign, the most prominent at rest. That pill rolling motions with thumb and fingers. I'm not sure if you guys have ever seen that in somebody, but it's kind of just like that. It's just like, moving your thumb and finger together. The tremor increases as the disease progresses, and it can include your hands, your arms, your legs, your jaw, and of course, the rigidity, resistance to movement due to involuntary contractions of the muscles. So that's really hard. So they have involuntary control of your muscles, which is just debilitating. First, obviously, you're going to be extreme risk for falls and injury, and the frustration level when you don't have control, obviously, is intense. Cogwheel rigidity, short, jerky movements of an arm. And again, I feel like you should definitely know these motor symptoms. More motor symptoms. Again, I want you to know the term bradykinesia because you're going to see it. So it's slowed movement. It affects both voluntary and automatic movement. Obviously, these people are going to have a lot of difficulty with activities of daily living, and they have good days and bad days. I've actually taken care of patients outside of the hospital with Parkinson's, and some days it's very difficult for. Oh, you're having a hard time hearing me? Is anyone else having a hard time hearing me? Oh,
I
okay, sorry.
no.
Oh, all right. I apologize. Well, it's whoever that was. That's you. I'm sorry. I'll try to talk a little louder though. So obviously, if someone's having difficulty, they have good days and bad days. I found it interesting very early on. I think I was 19. I was taking care of someone with Parkinson's. I did not know anything about Parkinson's. But inside the small confines of the bedroom, it was very difficult to move them. They couldn't really walk very well. He was always toppling over on top of me. And one day he kept insisting on going outside. And I thought, oh my gosh, what am I going to do? He's going to fall. But it was fascinating to me. So once we got outside, he just took off with these long stride movements. I don't know if it was the space or, obviously we know a little bit more, and it kind of waxes and wanes on the day, but it was just very interesting that happened. And that was, like I said, early on when I was first learning about it. But um, so some days are better than others. Steps may become shorter. So you'll see that definite and hopefully, I think we'll be able to see it in the video as well. The steps become shorter. The arms might not swing. That's one of those. That's one of those indicators that people see. That their arms are kind of staying by their side. Difficulty with speech, swallowing, and chewing. Right. So now and as a nurse, when I say these things, because I always want the focus to be on, our ability to assess and our symptoms and what our plan of care is. You have somebody that has Parkinson's disease, of course. You understand and know that they're at risk for aspirating, and you need to kind of incorporate that into your plan of care. And of course, as the disease progresses, you're going to want to continue to assess, right? You're always continuing to assess their safety level and their ability to swallow. So postural instability, stoop posture that leads to balance problems, falls, retropulsion when they stand up and they kind of fall back. And that's difficult, like when you're getting from a sitting to standing position. So safety is a huge risk for patients with Parkinson's. So now the non-motor symptoms. So cognitive deficits, slower thinking, confusion, memory loss, dementia later in the disease progression. So I talked about that Lewy body's dementia that can be effective. Emotional changes. Again, we talked about this depression, the fear, the anxiety, the absolute panic attacks, your inability. You've gone through your whole life being in control of not only your body, but your mind, and that's slowly deteriorating, and you're aware of it. Okay. So that's very, very difficult. Sleep problems, insomnia, restless leg syndrome. All right. Parkinsonism. If you could just pause on those because it's distracting me with the comments. Thank you. Parkinsonism. Oh God, Parkinsonism. No, Someone say it. Parkinsonism. Oh, I can't say it this morning.
Parkinsonism.
Thank you. Thank you so much. I'm sorry, my mouth is very, very dry. I appreciate that. All right. Parkinson's disease is a complex motor disorder, obviously, that we spoke about. And when you're talking about this, you're not talking about actual Parkinson disease. You're basically talking about a term used to describe the collection of the signs and symptoms, right, found in Parkinson's disease. And we talked about that: the bradykinesia, the stiffness, the tremors, the imbalance. Um, and there's other degenerative disorders that might cause those symptoms. And again, like I said, for example, the Lewy body's dementia. And so it's not, there's symptoms of Parkinson's disease, but it's not Parkinson's. So again, it can result from medications or head traumas. And patients with tremor, bradykinesia, rigidity do not respond to dopa. So not always, right? So I talked about the levodopa, but not some people with these side effects do not always respond to the levodopa. It just depends. But for your sake and for your knowledge, just know that levodopa is what we use to treat for Parkinson's disease. So unfortunately, again, there's no cure for Parkinson's disease. Obviously, neurology is going to be involved. This is the interdisciplinary team that I spoke to you about: the primary care providers, nurses, therapists, right? Speech and swallow, physical therapists, occupational therapists, the case manager, possibly the social worker. This is that whole collaborative team that we were talking about. We're working on controlling the symptoms, right? That's a big part of managing this disease. Is what can we put in place to control the symptoms, reduce depression, reduce anxiety, give the patient the tools, the education, the knowledge, to help them live through this disease along with their family members. So nursing care includes support for the caregiver, and especially as the disease progresses. Diagnostic tests. So this is just kind of a list of diagnostic tests. So using MRI, blood tests. They will have normal results from MRI, CT scans, and the diagnosis based on medical history, neurological, and physical exams. So it's a complete workup because, like I said, it could be other degenerative disorders. You do not need to know that though for the test, just so you know. I know someone's going to ask me. So surgery, so reserved for patients with advanced disease. So they have the deep brain stimulation, most common surgical procedure for Parkinson's disease. They implant a neurotransmitter into the patient to send electrical signals to parts of the brain. And that is in hopes of reducing the tremor, the bradykinesia, the rigidity. I know Michael J. Fox is probably the most prominent celebrity with this, and I know that he's had this done and he speaks about this. And they may allow patients to decrease dosage of levodopa. So levodopa increases the dopamine in your brain. So this is hoping that this will alleviate the need for that. Pharmacological therapy. So medications to reduce severity of symptoms. So again, there's no pill for this, but again, the pharmacology around it is going to be toward kind of reducing the symptoms and improving the quality of life, reducing disability, maintain the ability to work. So we're just going to get back to this. I mentioned this earlier. So as far as the medications, levodopa is the one that's most associated with the Parkinson's disease. It increases the dopamine levels in the brain. Um, it may not relieve balance and non-motor symptoms, but it helps reduce the tremors, that slow movement, the rigidity. And I will say that in my experience at the hospital with patients, I've learned that if I do not give that patient, and I know we talked about in the hospital, you can give a medication like 1 hour before or 1 hour afterwards, and it's not that not necessarily will be that harmful. But in the case of, patients with Parkinson's disease, I've definitely learned that that is something that you need to give on time, and the patients themselves will tell me that. And, one day I went to lunch and I, expressively said to the person that was taking over, "Please make sure that they get the levodopa at 12 o'clock. They have to get a levodopa." Well, they got called into something, and boy, did those, it was an hour late, and I felt extremely bad for this patient. I mean, it was the movements and then she was upset and she was like, I needed it on time, and she was really almost like projectiling out of the car. I mean, out of the chair. So it was very scary. In fact, we actually had to put, with her permission, she didn't want to go into the bed, but we actually had to put a lap belt on her, which is a restraint. But we asked if she wanted to stay in the seat, and that's what she wanted. We actually had to put that on because, at any moment she would just throw herself forward. So that was really, really sad. So on and off effect, sudden lack of symptom control, unexpected dyskinesia, what I was just talking about. Um, Sorry, my voice is so sore today. There's other drugs. The MAO-B inhibitors. You probably well, at least heard that. So that usually they try to use that prior to giving levodopa. It basically allows an increase. It basically blocks so that more dopamine is available. Okay, and that would work in conjunction with. But they also try to give something prior to that. And again, for your purposes, please make sure that you know what levodopa is and what it's used for. Other medications, the anticholinergics, I mentioned this before. Basically, these drugs block the acetylcholine, which is that neurotransmitter I mentioned before. And you'll see these kind of drugs used for people that have urinary incontinence or overactive bladder. So you might see this in your own patients during the hospital, like oxybutynin is used for that. But you'll also see it with Parkinson's disease because it helps block that involuntary movement. So again, just be aware these are medications that I'm not going to test you on, but I want you to be aware that um, there are a number of medications that are used to help kind of control the symptoms. And then, of course, the drugs for the non-motor symptoms are the antidepressants, antipsychotics, because again, we've got to treat the whole patient and all the symptoms. So lifespan considerations, early onset or young onset. This can begin before age of 50. It's a slower disease progression, and it's a lower rate of dementia. So women may be referred to a geneticist for concerns before conceiving if they have this. Effective Parkinson's disease medication on the efficiency of birth control is not known, so that's another reason. And however, there have been people who have been able to carry a healthy baby to full term. So just understand that there are some lifespan considerations in regards to Parkinson's disease. I'm just going to pause here for 1 second to take some water. So if you guys could just take like a 2-minute break, I'll be right back. All right. Sorry about that. Thank you very much. Any questions before I go on to the nursing process? The big thing, like I said. Oh yes, Denise.
So, I know we have to know levodopa, but is that the name that we need to know?
Yeah, again, I'm not probably even going to ask you, to be honest with you, I'm not going to, just know that levodopa is a medication that is used, for the dopamine levels for Parkinson's disease. I'm not going to really ask you any questions on any medications just to relieve your
Yeah.
mind. I
Is
just
it
want
the
you,
like? No, I mean, like, is it like a brand name or generic name or like?
oh, that's a good question. So that's all I know it by. Hmm, I don't know. Good
Okay.
question. Levodopa, carbidopa, I use that in the hospital. Hmm, good question. Dopamine levels. I don't know. But again, I'm not going to test you on the questions.
That's the brand name,
That is the
Professor
brand name.
Faraday.
Thank
Yeah.
you. I know I have a pharmacist. I know I have I know I have pharmacists in the
No.
area. I appreciate that, and I appreciate that because when you're in when you, and you'll learn when you get on the floor, you just kind of know what you know, and then you just kind of go with that. So I appreciate that. But I just think it's important that you do know that that's the one that's associated with Parkinson's, and it helps control those symptoms, which is, where I want your, which is what I'm always going to be testing you on, right? Like I want you to know, what the signs and symptoms are, what are the interventions are. All right. So, Aaron, can I do for you? Question.
Yeah, I know you said we don't like you're not going to test us on the medications
Mm-mm.
for the MAOB inhibitors.
Yeah.
It said like, well, I kind of have two questions. Like it says that it delays the need for levodopa, but it's also given with it. Can it be either or?
Yes. So initially, I think it's given prior to the need for levodopa, and then as the disease process continues, it's given together.
Okay. And then
Mhm.
it says that like part of monotherapy. What is that?
Which slide is that?
A pharmacologic therapy. It just has like the levodopa on top.
Hold on, let me go back.
After the one with the pictures of the pills.
Oh, thank you. Oh, so just that's what they're giving. That's earlier in the course, so that they're giving that drug prior for the need of levodopa. So giving a medication prior to going to levodopa.
Okay. All right. Thank you.
You're welcome. And like I said, it's a progression, and as the symptoms increase, they'll increase medications, they'll increase doses, and that's why as nurses, it's important for us to it's really important for us to document that, right? Like I find that more and more when I go into like nursing notes, it's like you've taken care of a patient for all day. And I think, maybe some of you guys have seen this, in your course of being in the hospital. But like, I think it's really important that if you have somebody that comes in with whatever it is, if it's Parkinson's disease. So I've read notes that patient has had Parkinson's disease in the hospital. It's not why they're there. It's part of, just because somebody comes in with pneumonia, but they have Parkinson's, we need to like continue to make sure that we are treating the comorbidities. That's part of our thing. So if somebody came in with pneumonia, but they had Parkinson's disease, and they have, you know, certainly signs and symptoms of it as well, I wouldn't just comment. Of course, I would initially comment on their lung sounds. Initially, I would start and say, patient's this, their lung sounds are this, their oxygen is this. But then, this is a disease process that puts them at a safety risk. Are we managing it correctly in the hospital? This goes back to our medication reconciliation. People are very fearful when they come in with this. Family members are calling. If the patient's able to tell me about their medications, they will. Like they understand that if this isn't done correctly, if they don't get their medications on time, if it's not the right dose, this is going to affect their quality of life, their quality of living. It's going to increase their risk of fall. It's going to increase their risk of aspiration. So it's really important that, we're documenting this in our note, even though it's coming in as a secondary comorbidity with this patient. You want to describe how the patient's doing during that day. And as you can imagine, anxiety, as we spoke about earlier, is going to exacerbate symptoms. So we kind of need to know that, because if the patient has come in well managed and then they're in the hospital and now it's escalating, we don't know. You can't make the assumption that, oh, this is the way they always are because they have Parkinson's disease. You just cannot do that. You can't do that with any disease process. So it's really important that you acknowledge this and address this in your note, and, make sure that, when you get to that SPAR part of your recommendation and plan, that you're addressing that and you're saying, look, this patient, which I had done with that patient, you must give this medication on time. If anything, come in 30 minutes early. You need to make the time. You need to make sure that it gets done. If you cannot do it, you have to send somebody in. So it's really important that that you're on top of that. So now this brings us to the nursing process. So I am going to go and read through these signs because I do think it's really important that you continually understand, this is what you do, right? Going through like the assessing, the planning, the evaluation, what your interventions are, and you're going to be constantly going to have to implement that. It's going to become just such an ordinary part of your practice and your day. You're really not going to think about it. And that's where you kind of want to be. I'll probably ask you questions on the nursing process, similar to what I did previously. I'll probably, give you, some examples of the nursing process and ask you, which one's the planning stage, which is the indication of like an intervention, and in the implementation phase, those are the interventions, right? And you should know those are really important. So monitoring progression. So patient teaching, we've talked about this, emotional support, assessing for changes in symptoms, the medication effectiveness. This goes back to what we had been talking about quality improvement, and making sure that, we are monitoring for the effectiveness of medications and, of course, any adverse effects. And again, we've spoken before about sometimes there's medications that are affected by other medications. So let's say someone comes into the hospital and they're on a regimen for Parkinson's disease, but they've come in with something else. And again, you can't know everything, and that's okay. Like you can't. I certainly don't know everything, and I use my pharmacist a lot. So if I have a patient that came in with Parkinson's, for example, and maybe I'm giving them an antibiotic or some kind of new medication for something else, and I've noticed that, maybe their symptoms are different or getting worse, maybe I call the pharmacist. Honestly, they're going to be doing that as well. I mean, they're going to be recognizing and knowing. I mean, that's their expertise. And I defer to their judgment often. And I spoke the other day about a pharmacist that come in, and the doctor himself was there and had no idea why the patient was exhibiting altered mental status. And as it turned out, and the pharmacist just popped up and said, well, it's because you're giving this and this. So I just want to say that and relieve your mind, because you can't know everything. Okay. But just know that, you can ask and you can find out. So assessment, obviously the core of your practice, your ability to observe the patient's gait and movements, and you want to document that. You want to use the proper words. You could use retropulsion. You could say unsteady gait. You need to assess whether the patient needs to be on an alarm. The patient that I took care of was perfectly fine all morning. Like she could sit there, she could feed herself, she could do all of that. But I knew, having had her all week, but by the afternoon, that was not the case. So in the afternoon, I got her up and I put her into the bed, put the guardrails up, and I stayed near the door to keep her safe. So you need to constantly be assessing your patient. Interference with mobility, work relationships, you need to talk about this. And when you become a nurse, you really become like a jack of all trades, and you need to be able to have those conversations, and they'll tell you, the patients will tell you, and they'll open up to you and they'll tell you, yeah, I'm having a difficult time. And you want to always kind of develop that therapeutic relationship so that, they are willing to tell you. I talked about that on and off of wearing of effects. And that's very frustrating. That's very frustrating. Use of assistive devices. Again, you have to be aware, yes, use assistive devices, but if somebody's using a rolling walker and they're having an off day, maybe that walker has now become a liability, because of the movements. And of course, the non-motor symptoms, which I talked to you about, which were the the depression, the anxiety, the worry about family. We talked about family-centered care. This is not just a disease that's affecting them, but it's affecting their family members, and they're concerned about that, and they're worried about that. And of course, we're going to make sure that the family is part of the plan of care, which we had talked about, and family-centered. So in that regards, obviously, I'm going to mention to you that we've talked about finding outside resources over and over again in many of our topics, that is part of our job. We have the case manager, but we certainly know and can acknowledge that there's outside resources to help with family support. And you'll see more of that in the video, but it's important to note that and remind you that all the learning that you have done this semester isn't necessarily from one topic to the next, that you have gotten to a point in your nursing now that this is all kind of integrated. All those interrelated concepts that you guys were introduced to along the way are kind of all coming to effect really almost in this last lecture together. So planning, right? You have to come up with a plan. So you guys go into your day at work, at the hospital for, your as a student, and you go in and you do your safety check and you do your assessment, and you come out and your professor says to you, "What's your plan?" I mean, that's key. What is your plan? And I know that because you've been doing this for a year, you're able to get that you're able to get there a little bit faster, right? And it can be, and it's simple. It could be as simple as, my patient will not fall. My patient will not fall today. And that's a good plan. Keeping somebody safe is a good plan, but you quickly, kind of prioritize your patients very quickly. You know it from your assessment, you know it from what somebody's told you, you know it from their lab values. So what is your plan? And my plan is, my patient is going to remain free from injury. I'm going to have them participate in OT and PT speech therapy, demonstrate normal bowel elimination patterns, maintain sufficient calorie intake. It just could be imagined that the patient's going to be, going to eat 75% of the meals today. All right. So your plan, what is your plan? Implementation, right? So these are the interventions. So I've come up with a plan, and now I need to implement them. So to prevent injury, I'm going to prioritize. Oh God, what is my talking today? Priority for patients with walking difficulties. Teach use of medications such as lift chairs, raised toilet seat. So again, I do a lot of education, especially if somebody's at risk for falls, and the person has Parkinson's disease. I mean, at this point, they're familiar and aware, but sometimes, you need to continue to re-educate. So please make sure that you use the call bell, prior to getting up. Installation of handrails, removal of floor hazards in the home. Okay. So these are some of the things to optimize mobility that have been researched and used for Parkinson's disease. So you encourage patients to walk daily and to participate in exercise program, strength training, range of motion exercises, treadmill walking. Again, it depends on where they are in the disease process, okay? Because we always have to prioritize safety. And again, these symptoms can kind of wax on and walk off during the day. If the patient cannot ambulate independently, caregiver should help patient ambulate several times a day, right? So again, that goes back to making sure that the patient is part of the plan of care. Teaching techniques for proper walking, methods to maintain balance, encourage participation in PT and OT. So that goes back to that collaboration that I was telling you about, involving physical therapy and occupational therapy. You want to try to get as many resources in as you can. Remember, we're working with our case manager, sometimes our social worker, PT, OT, speech and swallow, which will help identify any difficulty swallowing or any progressive with difficulty swallowing. And we'll talk a little bit more about that later at the end. All right. So again, this is a list of implementations that you would use on your care plan if this was your patient. Remember their action words: encourage patients to take adequate time to form ADLs, encourage use of assistive devices, suggest referral to speech pathologist, train caregivers in assisting patient with hygiene. So again, that's part of your job as nursing. It's not just patient-centered, it's family-centered. Provide information about vocal training, good sleep and hygiene. So again, always education, education, education. and then determine which ADLs are causing most difficulty and address them. And you can involve certainly, occupational therapy in there as well. So now you want to evaluate. So you went in as a nurse, this was your patient, you came up with a plan, you implemented your interventions all day, and now you're at the end, and now you're evaluating them, okay? So assess patient's emotional status at each interaction, assess patient's support system and research at each state of the disease, make referrals as appropriate. So what I'd like to do now is I just want to pause here, and we're gonna watch this video. We are gonna come back. And as you're watching this video, because I want to ask you a number of questions, it's 12 minutes long, which is the longest video I've given you, but I think it's really important. And I really think it'll kind of give you an idea of not only the struggles the patient themselves have, it also will give you a view of what a patient with Parkinson's might look like. It'll also give you an idea of the caregiver role strain. So these are all topics that are preparing you for your final exam as well, okay? Because these are all topics that you and I have talked about together, and these are the same things that I've tested you on, right? Caregiver role strain, family-centered, family dynamics, and I think you're going to see all of that in this video. So I'm happy to answer any questions for you and hear about your thought process on that. So if you just give me 1 minute, I'm just going to share it. Oh, hold on. I got to turn off my mic before I do all that. I apologize.
I was in the Army from 1956 to 1976.
Well, we met on a blind date many years ago, like 55 plus years ago. And he just knocked me off my feet.
I was diagnosed June 2003.
Professor, I don't think you're muted.
I'm going back. I'm sorry. I thought I did. I apologize, guys. 2 seconds. Oh. Sorry about that. Can you guys hear me?
Yes. Yes.
All right. I apologize. I'm going to go back in and I thought I had muted it. Thank you for letting me know.
Anonymous is also not muted.
They're a very, very close couple.
I was in the Army from 1956 to 1976.
Well, we met on a blind date many years ago, like 55 plus years ago. And he just knocked me off my feet.
I was diagnosed June 2003.
They're a very, very close couple who, as the disease progressed, Dale has taken on more and more of his care.
She feeds me. I mean, she cooks for me. And she gets me where I got to go. And she puts Bactine on my scrapes and helps me bathe and dress. She has good taste in shirts. And she puts me to bed at night.
He falls almost every day. I don't think we've had it hardly maybe 2 or 3 days that he hasn't fallen. And they're always near falls. Had a terrible fall in the garage and hit his head, and you know, the blood was spewing, and we ended up going to the emergency room.
I've been fortunate. Only thing I've broken a couple of fingers so far.
To see it is very scary, and you just kind of feel like you're sitting on a. I feel like I'm sitting on a keg of dynamite.
I think it's normal to have negative feelings when you're dealing with something that's very difficult.
I don't scream, but I talk louder. One day, Jerry said, I said something about, please don't do that. And I didn't think about it, but he said, you didn't ask me that very nice. And I said, well, I said, please. He said, but you used please like a 4-letter word. I said, I'm sorry.
Many caregivers will mention that they feel guilty that they're not able to do more, or that they feel guilty about their negative emotions. And the first question I ask them is, do they think that they're perfect?
I'm a human being, you know, and I do make mistakes, and good Lord does forgive me, and I have to forgive myself.
As Parkinson's disease progresses, the relationship with their spouse changes a lot.
When you become a caregiver for someone with Parkinson's disease or a serious disease, the number of hats you wear increases, and the frequency with which you wear those hats increases.
I worry about the role change that's happened, you know, and that's just really very difficult.
So an example of that may be that the spouse is now having to manage and take care of all finances, or manage and take care of yard work outside.
Making decisions by myself or discussing it with the kids, because Jory, really, we're not discussing those kind of things that much anymore.
Caregivers often describe a loss of relationship. And what that really means is just the shared intimacy they've had over years can be really impaired.
That's one of the hardest things that we've lost, is the intimacy we had. But, you know, we hug, we kiss. You know, when I go in to get him up in the morning, I always give him a big kiss. And we never go to bed without kissing each other goodnight.
When you have Parkinson's disease, there's so much decline in your facial expression and your gestures that it's often hard to tell what a person with Parkinson's disease is feeling unless they really tell you.
With the masking that comes along with Parkinson's, you can't tell whether he's laughing or not.
So really working hard to communicate about what's going on with them, and asking their spouse about how they're doing is a very helpful thing.
Talk to each other about it. I think you really need to talk about some hard things.
People who feel like they want to be heroes, or that it's their duty to be 24/7, always, typically burn out.
I knew I couldn't do it all, And that's another reason I got help early on, and I also started thinning out my own activities, because I find when I'm trying to do too much that I get really short and I get really tired.
Caregiving is hard on a caregiver. And there has to be some time of relief.
Assessing for caregiver strain, if we want to use that word, is really important for clinicians to do, and it's not always easy to tell. Sometimes it's obvious. They're so stressed and they are so depleted that they can't begin to hide it.
She was talking about something and I just broke down in tears. And so yeah, a couple of times that's happened in the office.
Other times it's not as obvious, even if you're sensitive to it, because the natural tendency when you're a healthy spouse, is to feel that the real focus should be on the person with the illness.
You do try to be strong though.
If caregivers seem like they have a lot of strain, I often will refer them to social workers, to psychologists or other mental health providers for support.
We try to tailor our interventions to meet the person where he or she is. And so one day we may be doing nothing but sitting down and listening and doing supportive counseling, encouraging. And the next day we may be providing a lot of linkage to resources.
The person with Parkinson's disease often feels like all the giving is one direction. And it's so helpful when they feel like they can do something for their spouse who's doing a million different jobs and doing a million different things. And one of the things they can do is to just acknowledge how hard it is for them.
Watching my wife work to keep me going is hard. She's been with me for 55 years and has been through a lot.
I think the second thing is to encourage them to take time for themselves. And if that means somebody else has to come stay with them, or their spouse does that, that's so validating.
Hello there, how are you?
How's Jerry doing today?
He's doing pretty good.
Okay.
Oh, so good to see you.
Jerry said he didn't really want anybody, because he didn't need anybody. And I said, well, I don't know that you do, but I do. And he's really been very open to that.
It's been pretty easy for me. I'm not super self-conscious when I have to be assisted.
She's free to do many of the other things that need to be done in their home.
I've always shopped, major shopping, like once a month or so. We used to go grocery shopping together, and now I go by myself. Mainly I get produce and fresh vegetables and things like that. With two of us, there's not that much of a major shopping anymore.
Caregivers who are 24/7 truly need time away.
Oh, I don't know about that. It's a little crazy.
I have a group of ladies that they get together on Monday mornings, and I've just started going back, and I try to go to that group almost every Monday, but I can't always make it.
Respite care simply means time away from the duty that you have.
That can occur in the community, where the patient with Parkinson's goes to a place where there's trained professionals to help care for the patient. Or there can be people that come into the home, and the spouse, the caregiver, can then leave and do things that she feels she needs to attend to.
I think of it as a time sort of to fill up your tank so you can come back and be re-energized to do the job at hand.
There's respite care for the VA, through VA, and like you can have a week. I'm not quite sure, but I'm not ready to go there. I don't think Jerry's quite ready to go there either. So, and I'm hoping I won't have to do that, but I may.
Many people have many built-in supports, either through their church or their family or just their social circle.
Your friends and loved ones want to help you, and that's their way of sharing, you know, and their way of being a part of the friendship, you know. And when you let people help you, it's such a blessing for them and for you.
I think there are also some great caregiver support groups out there for Parkinson's disease.
She has her Bible study group that she meets with.
We both have really strong faith, and that's just been really wonderful. I don't know what I would do if I didn't have that.
Caregiving is just simply hard, and that as a provider, healthcare provider, it's as important to care for the caregiver as it is for the person with Parkinson's disease.
We need to tell caregivers that they're doing a tremendous job, and their job is obviously incredibly important, and that they're a valuable member of the care team.
Many caregivers describe a silver lining of caregiving. They talk about meeting people that they wouldn't have ever met before. They talk about a closeness of relationship because they need each other more.
Life was not perfect, and life does have lots of pain with it. But there's a lot of good that comes out of those things. You know, I've seen it through my life over and over again.
Some people have talked about the personal growth that they themselves have achieved by doing something so difficult and recognizing that not only did they do it, but they did it pretty darn well.
Okay, so I think that was important. There's a lot of things that jumped out from that video to me, and I want to get your thoughts on it. And again, kind of refresh your memory as you are planning for the final exam on some of the topics that we have talked about. I'll just mention them now in case you know, we lose time. But remember, we've had discussions on teamwork and collaboration where we talked about the interdisciplinary team members and obviously the family dynamics using our the family role strain. So I just kind of want to jog your memory a little bit, and we'll talk a little bit that as we dive into this video a little bit. But just starting, just to start, and like I said, I think there's a lot to dive in here with. Can someone just you know, talk to me a little bit about some of the symptoms that you noticed in the patient himself? Aaron.
The first thing I noticed was like his head seemed kind of stuck in that like one position.
Yeah.
So that's the rigidity and his slowed speech. And then when they were like leaving the house, he took very small, short steps and he used his walker.
Yeah.
But I also noticed that the wife had like kind of her arm around his, like keeping him very close to her to prevent a fall.
Yeah. Absolutely. Good. So those are definite symptoms. And then maybe some of like the lip smacking with his tongue, like you said, the slowed speech. Overall, he presented pretty well. I mean, I'm sure, you know, he has better days and worse days. Anyone else want to comment on anything else about him or his thought process or, you know, his emotional stability? All right. So, I mean, Karina, go ahead.
So I kind of noticed that he didn't really have any facial expressions. So he didn't have like sadness or look at her with like love. I mean, of course, it's video, so they might have cut those things out, but I felt like he talked without emotion. And then also his left side, he was not using his left arm. for anything, like he was using his right arm when he was eating.
Yeah, and again, remember we talked about that it usually starts unilaterally and then it will go bilaterally. And then the masking that you talk about, right? Like he cracked a joke, right? Like he was joking about his shirt. And that's sad. And from a caregiver standpoint, that is difficult, so like you said, not to be able to have somebody to be talking to them and not be able to discern the things that we take for granted, because of his speech pattern and because of his face, not being able to discern that. So it's a very emotional, it's just very emotional. Fallon, go ahead.
Yeah, he kept mentioning how his wife takes care of him all the time and she does all the work. And not only was she saying how her life revolves around him, but how he knows it and how hard it was for him to see himself get worse, not be able to do anything about it, and have his wife have her life revolve around him.
Yeah, and that's when we talked about earlier. So that depression and anxiety that you can only imagine, has to come. Here's a man that, based on their history, is taking great pride in his relationship and probably taking care of his wife. And now, and I'm sure she took care of him equally, through their marriage, but now the dynamic has really shifted. And that takes a tremendous amount of toll, psychologically. Anna.
Yeah, I was just thinking about how the masking, it's hard on the caregiver, but it's also hard on the patient because he can't communicate. You don't know he's, making a joke, or he can't convey how much he loves her or how much he appreciates her. And it's hard for them to be part of the communication and the people that are around them because they can't communicate.
Yeah. So again, communication could be part of your plan of care. And again, talking about it, like, acknowledging that with him, that I know that you can't express that. But with education, he can still articulate it, he could say, I wish I could, this, but this. So it's about education and support and understanding, both for the patient, and the family member. And then what about the resources? Can anyone talk a little bit about the resources that she had available to her? Nicole. Yeah, the VA. And where else? Any respite care. Yep, the respite care coming in. What else?
She also mentioned her children, collaborating with her children to make decisions.
Yeah. Psychiatry support. So this sounds great, right?
The support group too on Mondays. Sorry.
Yeah, no, absolutely. So when you look at that video, you think, well, this is what I thought. I thought this is as good as it can be, right? She's got VA, she's got a psychiatrist, she gets to meet her friends. She looks like she's in fairly good health. She's got people coming in to help her. So, yep, and she has her faith, right? And that's part of our collaborative team, right? Spiritual care. So if you were if you were taking care of this patient in the hospital or outdoor setting, and that faith is important to that family, you would certainly ask if you want spiritual care involved. Is that all sounds great, right? But what about all the people that don't have that? Like, did anyone think about that during the video? I'm interested to hear your opinion on those of you who have been in caregiver role strains too. That she has an extreme support system, it seems. It doesn't make it any less difficult, but she certainly has it. But what about those caregivers that don't have all that support? I was curious if anyone was thinking that going through. Anna.
Hi, I think that she had the ideal situation, and I think 95% of the people don't have as much support as she did. I took care of a patient with Parkinson's, and the family had 3 kids, none of which lived in anywhere near here. It was just the wife doing it all on her own. And they were able to hire an agency to come in 3 days a week and help her for 2 hours, but that's not enough. And then when the agency doesn't show up, the person from the agency doesn't show up, it's all on her. And it was very frustrating. And the other thing I noticed about her was she was very reluctant to use the respite care.
Yeah.
And I think that, I think the family needs to be encouraged to use the care that is
Yeah.
available to them and not feel guilty about it. Because I know when I first started taking care of my father, the guilt is amazing. Like you
Yeah.
think that you should be able to do it all. You know, this person did so much for you, you should be able to do it for them. So it's about encouraging the family members to accept the help that's available.
Yeah, and hopefully you guys take all of this into your practice, because again, it becomes just like we have learned and through videos and discussion that people as nurses, we become complacent with maybe our medication administration. You know, you can kind of be complacent with your care, you know, your actual care of patients and their family members, and recognizing that it is your job. It is the foundation of your practice. Your caring is the foundation of your practice. And to recognize that it is family-centered care. And this is not just something that, you know, we talked about in nursing school just to get through nursing school. This is a foundation of your practice, and your ability to recognize that not everybody is fortunate to have those resources. And that's why you involve people like the case manager. And then perhaps in situations like you've talked about with that patient's family, maybe once they get into the hospital, you know, take advantage. I always try to tell family members when they come into the hospital, because there's a lot of resources there, to kind of take advantage, because they can start those VNA services. And then there's also volunteer groups in the community. And then certain people qualify for actually at-home visits. So really, as nurses, you really need to be advocating and finding those outsourced resources, or finding the people that know them. Let's see. Anyone else want to comment on anything that they had seen? Jessica.
Yeah, I recently had like a personal situation, I guess, where like the caregiver strain was so bad and it had gone on for so long that there was this huge like relief when the patient finally passed, which also led to like a lot of guilt that they're working through still. But that's like another thing, like you would never think to be like relieved that your husband passed away, but it was like a huge factor.
Yeah, absolutely. And that's where, again, your role as a nurse comes in, to let them know that it's okay. And then just empathize with them. You know, you just say, I know this must be difficult for you. Those open-ended questions that you kind of talk about. And again, and if they say, well, if my faith is important, you know, you can say, well, we have, you know, clergy here. Would you like to come up? You know, it causes anxiety and depression, and not only the people suffering from whatever disease it might be, but also the family members as well. And again, one thing that I noticed is that she's, like I said, she's in okay health, but what if in one of those falls he takes her down? That's going to change that's going to change the whole dynamic. Anyone have any thoughts about his falling? Anything pop into your head when you thought he fell, now that you've been here a year? Is there any medication that he might be on that you were concerned about when he fell? Anyone want to jump in on that? Karina.
Blood thinner.
Yeah, blood thinner. Yeah, that's the first thing.
Like I don't know if they give muscle relaxers for like the
that
tremors or something.
Yeah. So maybe too much of something. I don't know, but what his situation is, what his medication is. But I know when he fell, the first thing I thought of was if he had been on Eliquis or some kind of blood thinner, that you know, that's dangerous, because they can also fall and there might not be signs of bleeding, right? It might be internal bleeding. So then as a nurse, if this was your patient and he fell and he was on blood thinner, of course you would have to assess for signs and symptoms of that. Okay, at the site, any bruising, also you're monitoring their H&H and other assessments. So I did think of that. Let me see what else. I wrote a couple other things here. Anything else that jump out on anyone? We talked about the masking and the symptoms, the caregiver role strain, all the interdisciplinary teams, the family dynamics. Trying to think for your test, things that we had talked about previously, the slow speech that he had. So when you think about something like this and you implement your plan of care with somebody like himself, if he came into the hospital, again, you'd be making sure that he got his medication on time, making sure he has the right devices. You would be making sure that the patient's going to, be free from falls by the time he comes home. educate patient on safety measures. You would have the family member participate in the development of the plan of care. And these patients sometimes have to go to long-term care. And that's also very difficult, again, for the caregiver, because they don't have the resources, so then it has to go to the courts, and they have to sell their house, and they have to go to on Title 19. I mean, it's very debilitating all around for anyone. So that's it. So that's again, it's on stress and coping, but I wanted to, the concept of stress and coping, I want to introduce Parkinson's disease to you, as it affects, as it relates to stress and coping, as mobility relates to stress and coping, and some of the things that, we can do to alleviate that, the anxiety and the depression that's related to it. You want to make sure that the signs and symptoms, the bradykinesia, the rigidness, the pill rolling. Okay, so just be aware of the signs and symptoms. And as I said, please make sure that you are aware of the interventions that you would do for the patient. You certainly want to be aware of the concept of the nursing process. So any other comments or questions or anything that they'd like to ask before we go today? Heidi.
Hi. So when you were talking about assessing the tremors, is there some type of scale, like the fall scale, or is it just,
No, it's a good question. No, necessarily, but you would write in the if it was my patient, like I would say, so if it was your note, you would say, write, like, if he was first coming to the hospital and I was assessing him, just so the doctor knows and the rest of my team knows, I would say lower extremity, mild tremors. And then I would make sure I say that this is his baseline. So because what happens is the next nurse is come in and say to you, is that his baseline? Like, does he always tremor? Is this new? Do you know what I mean? So you want to say baseline bilateral hand tremors, mild bilateral hand tremors. And then maybe the next day you come in and, it's, the moderate bilateral hand tremors, or, patients, inability to hold cup. Then you want to kind of give like specifics. Do you know what I mean? So you're just assessing to the best of your ability, but it would usually be like mild, moderate, or severe hand tremors.
Okay.
I don't know if I answered. Yeah.
Yeah. No, thank you.
On that? So again, if there's no other questions, I just want to make sure that you know that I'm available. I know you guys are studying for your exam, so you can certainly reach out. I've tried to kind of give you an idea of some of the things that I'm going to be revisiting with you. You've all done really well on it, so I'm not concerned. But if you have any questions about any specific topics that you've learned from me studying, please let me know. And then certainly, anything today that you'd like to review. I just want to say again that, I appreciate your time and your attentiveness with me and my inability to speak, I guess, today. But I appreciate it. I really wish you guys nothing best going forward next year, and certainly you're welcome, and certainly for your exam in next semester. And of course, I'll always be around next year, so please stop and say hello. I'm sorry we weren't able to do this in person. I think I'm going to enjoy that a lot. It's weird talking to the screen, but I appreciate your patience and my and everything. All right, great. Thank you very much.
Professor, aren't you don't you teach? Sorry, my son. Don't you teach next year?
Oh yeah, so I do teach